Hello everyone, Dr. Hall here. Continuing on with our lecture about birth, part B, we're going to talk about stages 2 and 3 of birth, which are pushing the baby out, otherwise known as fetal expulsion, and delivering the placenta, otherwise known as placental expulsion. So in our last lecture, or mini lecture, we talked about labor, which is that sequence of regular uterine contractions of increasing strength and frequency, mediated by that positive feedback loop of the pressure of the baby's head against the cervix, which stretches it, sends signals up to the brain, causes the pituitary gland to make more oxytocin, and oxytocin therefore stimulates stronger and more frequent contractions. So a positive feedback loop that ultimately results in the cervix being completely thinned out and dilated to 10 centimeters so that it is no longer keeping the baby inside the uterus. So at the end of that first stage of labor, now finally, after hours and hours and hours, the woman can actually push. And she'll usually feel a very strong urge or desire to do so. It kind of feels like you really need to go to the bathroom. All right, so the cervix is fully dilated. Now you can start to push, and it's kind of like trying to take a really large bowel movement, right? So you have to kind of push down with your abdominal muscles, but relax your pelvic floor muscles so that you're not kind of fighting your efforts. And so what the pregnant person will do is push when they have contractions, because contractions are still happening. And so what they'll do is they'll add their voluntary pushing to the uterine contractions to move the baby down through the pelvis, because remember, that's a pretty narrow space. It's going to be a tight fit, and then out through the vagina and out the vulva, which is also going to need to stretch. So this process of pushing, it really varies. Some people, especially if it's not their first baby, and especially if it's a smaller baby or they have a roomier pelvis, by which I mean a bony pelvis, you can't really tell that necessarily by looking at how wide somebody's hips are, for example. It can take only 5 or 10 minutes and a few pushes, or it can take hours. So it depends on the size of the baby, the size of the woman's pelvis, and also sometimes the way the baby's head is situated in the pelvis, and if it's kind of tucked into the most aerodynamic position as possible or not. So we see a few images here of very different birth settings. In the lower left is a very medicalized birth setting, and you can see there's an oxygen mask on the person. They have a lot of monitors on. There's an IV. So this is a pretty medicalized birth. They're probably having some complications, and you can see they're getting an infant warmer ready in the background. And then at the top right, we have a water birth, right, happening. This could be at a birth center, in a home, or even in a hospital. A lot of hospitals will have tubs for women to labor and push in. And in the bottom right is a hospital birth in a maternity ward. And you can see it looks like she's got maybe her parents or friends there supporting her as she works on pushing and bearing down. So the pubic symphysis, which is the bony part way in the front, so right where the mons pubis is, if you kind of feel you have a tough bone there, and that's actually two bones that come together in the pubic symphysis, and they can separate slightly to give a little bit more room for the baby's head. And as this whole process is occurring, the fetal head is going to have to move in a specific sequence of ways in order to fit through. So we see in this first image up here that, before the fetal head is actually against the cervix, it's just floating. And then engagement here is when it's actually pushed against the cervix and starts to dilate it. As the woman is pushing, then, what's going to happen is you can see the fetal head extends, almost like they're kind of looking up a little bit, but they're also face down, right? This is the vertebral column back here and the spinal cord. This is that pubic symphysis up front. So birth is easiest and most commonly happens with the fetus being kind of face down, right? So it's going to be pretty much face down, getting ready. And then as it first starts to come out, it's going to really, the head really extends, and then it's going to rotate. It does this really interesting thing where it just swivels by about 90 degrees. So then it's facing sideways so that you can get the shoulders out. Okay, so there's this whole sequence of movements that happen, and so showing you that diagram was one attempt, but there's actually a really nice video that is kind of an animation of what happens during this process that I'd like for you to pause and go ahead and take a look at that. So as this is happening, eventually the baby's head is going to get down to the point where it is stretching and distending the vulva, right? So those labia minora are having to open up and stretch. So here is the perineum here, which is that skin between the anus and the end of the vulva, and that's going to have to stretch as well. And so as these tissues stretch, we call this crowning. You can see because it's like the vulva is kind of making a crown around the baby's head. People who have gone through this process will often describe it as a ring of fire. So lots of stretching, pretty painful generally, but it also means that you're getting really close. So it can take lots and lots of pushing to even get to this point. So we can see in the right-hand image that this woman, they've said, go ahead and touch your baby's head, because sometimes you've been pushing and pushing and it just seems like nothing is happening. But if you can actually feel like, oh yes, the baby is here, it's coming, that can be really helpful in giving you that extra motivation and drive to keep pushing even though it's painful. So crowning will continue. You can see here the baby's head is almost all the way through. And so this vulvar skin is made to stretch. And so in about half of people, it stretches just fine without tearing at all. But in about half of people, they'll have a tear, usually kind of down here. The skin can tear a bit as the fetal head is coming out. In this middle image here, we see that the midwife or obstetrician or family doctor who is performing the birth is controlling the fetal head to make sure that it doesn't come through too quickly, because that can increase the likelihood of tearing. And then in the right-hand side, we see an image that the baby's head has now come out, and they're starting to turn to the side. They were face down when they first came out, and now they're facing to the side so we can get the shoulders out. But you'll also see that the umbilical cord in this particular case is wrapped around the baby's neck. So one of the things they're going to do first is untangle that so that as the baby is born, the umbilical cord doesn't get torn. So in ye olden days, and sometimes still today, obstetricians would cut what is called an episiotomy. So an episiotomy is using some scissors to cut the perineal skin to make more room for the baby to come through. This can make the process of delivery much faster because you're not waiting for the skin to stretch naturally on its own. You're just kind of cutting it open to give more room. The original thought behind this was that it makes things quicker and therefore less difficult on the laboring person. The other thought behind this was that if you have kind of a straight surgical cut made with scissors, that when you sew that up, it would heal more nicely than kind of a jagged tear if you let somebody's skin just spontaneously tear on its own. That has since been shown to be false. The perineal skin is actually very good at healing the vast majority of the time. The other thing is that episiotomies can make things a little bit worse potentially. So if, for example, you've ever cut up an old towel or an old t-shirt to make rags, and you might know how if you make that first cut with the scissors, then you can just pull and tear the rest of it. So what we do find is that with people who have episiotomies, it does increase their risk of having a very large and significant tear. And what we worry about is a tear that goes goes all the way down into the anal area, because those are associated with a lot of complications. So we want to avoid that if at all possible. So an episiotomy is not usually needed. Usually the risks outweigh the benefits, and so it's not recommended as standard procedure. If there's some type of an emergency or some type of a problem and we absolutely need to get the fetus delivered quickly, then yes, an episiotomy makes sense. But you have to weigh the risks and the benefits, and for a standard healthy delivery, the risks generally outweigh the benefits, and you should let the skin stretch on its own. And if it tears on its own, it tears on its own. It's fine. Those heal just as well with stitches as the straight cuts. So this is that information in text if you needed to quick review that again. So the other thing that's happening, right, while the fetus is being pushed through this narrow space is that it is specially adapted to be able to change its head shape in a way that makes it easier to fit through. So the fetal skull is not fully fused. They have separate bones that are not yet attached to each other. So they have these separate bones with these spaces in between, right? And so those spaces are called fontanelles. You can see this one here. You might know them as soft spots, right? So if you've ever seen a baby's soft spot, if you've ever touched a baby's soft spot, you are basically touching on their brain, which is in here. It's underneath a membrane, but yeah, that would be their brain. But so the cool thing about the fetal skull then is that those bones can shift and mold to become more aerodynamic, so to speak, so that they can fit through the pelvis. So it gets kind of molded into a cone shape. So you can see this baby's head here is kind of elongated, kind of a cone shape. So most babies that are born vaginally will have some extent of a cone head. Sometimes a really severe cone head if the pelvis was very narrow, sometimes not very severe if the baby is small or the pelvis was wider. This will resume, the head will resume its normal rounded shape over the course of the next several days, so it's nothing to worry about. This is something that they're built to be able to do. And then later in life, once their skull is finished growing, those fontanelles close and the bones of the skull fuse. So none of us, right, have open soft spots anymore. Those close early in infancy and childhood. So a special adaptation to allow for squeezing through. The other thing that we have to think about with pushing is that although generally the head is the biggest part of the fetus to come through the pelvis and the vulva, sometimes the diameter from one shoulder to another can be even larger than the diameter of the head. And so sometimes what can happen is something called shoulder dystocia, where this shoulder here gets stuck behind the pubic symphysis, behind that bone. It gets kind of wedged and jammed up behind there. If that happens, that is a life-threatening emergency for both the mom and the baby. Because what happens in this point is the head is already out. The umbilical cord at this point is probably getting really squeezed and trapped. The baby can't breathe because its chest is squished in the pelvis and it's not getting oxygen through the umbilical cord. So this is potentially fatal to the baby, and if you can't get the baby out, then that can be fatal to the mom as well. So this is an emergency. There's lots of maneuvers that we do as healthcare providers to try to get that shoulder out. Lots of changes in position for the mom. And sometimes if things are really bad, even kind of breaking the baby's collarbone to get them out, which sounds horrible, but it's better than them dying, and it usually heals quite well. And in fact, I don't know if you noticed, but in the video, well, no, I'm going to show, it's going to come up later. There's a YouTube video of a home birth that is not graphic. It's quite lovely. But if you pay attention, there's a point where she's pushing and she's very uncomfortable. And the midwife says, well, the head is out, but then she's still having a lot of difficulty getting the baby out. That's shoulder dystocia. And if you pay close attention, you'll see they edit out part of the video there too, and then they cut to when the rest of the baby is delivered. So there's a little bit of mayhem and chaos there as they were working to get that shoulder out and alleviate that shoulder dystocia. And so this is that information in text. So generally, once the head and shoulders are out, usually the rest of the baby comes out pretty easily. I had a couple of births that I did where the belly was really big, but at least that's squishy. So even if it's big, you can get that out. Then the rest of the baby is delivered. Again, we see two kind of very different birth scenarios. One is a home birth with a midwife in a tub, and the other one is a hospital birth. That's pretty medicalized. This was probably someone who had some complications. So once the infant is out, a few things have to happen. One is you need to dry it off, right? Think about how cold you get if you step out of the shower on a chilly day and you don't dry off right away. And the nose and mouth are going to be suctioned with a little bulb suction thing to remove amniotic fluid, because they've actually been inhaling amniotic fluid for months. So the other thing that's going to happen then is we're going to stimulate the infant to cry. We don't hold them upside down by their feet and spank them. Usually we just rub their back to help them start breathing, because they haven't really breathed air before, and to get those lungs all stretched out and expanded and filled with air. The umbilical cord will then be clamped and cut. So you can see here there's a little plastic clamp here, and then a metal clamp here, and then you cut in between the two so that then it doesn't leak blood all over the place. And you can see the umbilical cord is really kind of cool looking, and remember that has the blood vessels that go to and from the fetus and the placenta, so bringing nutrients and oxygen to the fetus, taking waste products away from the fetus. So we're going to clamp and cut the umbilical cord. And this period right after birth is really critical for the infant, because it has to do two things that are really important and difficult to do that it's never had to do before. So it has to regulate its own body temperature. Until now, it's been in a 98.6 degree jacuzzi, basically. So now it has to regulate its own body temperature, which is totally new. And it also has to breathe for the first time. So that's why we stimulate them to cry, is to help them kind of get those lungs going. Now, sometimes people say, well, I don't want to cut the umbilical cord right away. I want to allow the baby to transition and get their breathing established before I cut off that supply of oxygenated blood from the placenta. Because if you think about it, the other end of this umbilical cord is attached to the placenta, which at this point is still inside the uterus. So at this point in time, the baby is out, but the placenta is still inside the uterus, and you have the umbilical cord attaching the two. So some people will say, well, let's wait for a few moments, let the baby transition, and then clamp and cut the umbilical cord. And actually that's been shown to improve infant outcomes. So a couple of minutes of delay is a good thing. What is not such a good thing, however, is this. So we haven't talked about delivery of the placenta yet. That's going to be stage 3. That's going to come next. But here is a placenta which has come out from the uterus, which would be stage 3. And it's kind of a cool picture because you can see how the umbilical cord is going from the infant to the placenta. What gives me the willies about this picture is not that the placenta looks kind of weird and gross, because I'm beyond that, right? But I apologize to those of you for whom this is really uncomfortable. But this is the smooth surface of the placenta that's covered by membrane. The undersurface of the placenta, which we can't actually see here, is very rough and raw because that used to be embedded in the endometrium. And so they have now placed this raw surface on what I can only assume is a non-sterile blanket. And so there is a direct potential communication from the blanket, any germs that might be on the blanket, into the placenta, and possibly through this umbilical cord that they have kinked into the word love and into the infant, right? So delayed cord clamping, sure, for a few minutes, but we absolutely do not recommend that you leave it this long or that you keep them attached when the placenta then can come into contact with things that might potentially have bacteria or other things on them. So just a few minutes. All right, so just a reminder again that the infant is now having to breathe for the first time ever, and so we section the fluid out and the infant starts to breathe. Now when they first come out and they're first starting to learn to breathe, look how purple this baby is. Okay, so when most babies are born, they're purple cone heads, right? They look pretty strange, and then as they start to get the hang of this breathing thing and get their own oxygen into their bloodstream, then they look pretty pink, right? So then they kind of pink up, but you may notice that right here around the mouth, things still look a little purplish, and sometimes they will still look a little purplish or bluish out on the hands and feet as well. And that will usually persist for the first day or so as we're waiting for some structures in the fetal heart to change and be optimized for oxygenation of the blood through the lungs. So this is the video of a birth. It's not graphic. There's really no yucky stuff. There's a lot of footage of her in labor, and she's really a very stoic person, and the birth goes pretty well. Although if you pay close attention, you'll see that there is a little bit of trouble with the shoulders there, but it's quite lovely. They do wait quite a decent time before cutting the umbilical cord. But there you have it. So stage 3, as I've already alluded, is delivery of the placenta. So anywhere from 1 to 30 minutes after the fetus is delivered, the placenta is then going to detach from the uterine wall. Okay, so it was embedded in that endometrium. It's going to detach. This is usually signified, there will usually be a little tiny kind of gush of blood that comes out the vagina, and then we know, okay, the placenta is detaching. And then we'll ask the woman to give a couple of pushes to push the placenta out. And the placenta is soft and mushy and easy to pass. Although I'll never forget one time I was delivering a baby for a patient who wasn't my regular patient. I happened to be on call and her regular provider wasn't available. And so we delivered the baby, everything was going well, and then it was time for her to push the placenta out. And so I said, okay, I need you to give me another push. And she looked at me and she said, "There's another one?" So she was worried she had twins because I was telling her to push again. So she hadn't gotten the message that she would have to deliver the placenta too. But that's usually pretty easy. So that's good. All right, this is what the placenta looks like. It's kind of a color picture, and you can see here's the umbilical cord, and this is the smooth surface of the placenta that was facing the baby. The rough surface that was kind of like Velcro interdigitated into the uterus is not visible in that view. Here is a picture where you can see here's the smooth surface, and this is where the baby was. Right? Baby was in here. This is the amniotic sac, and then the rough undersurface of the placenta that was attached to the uterus is here. So after the placenta has been delivered, you have this raw area on the uterus where it used to be attached, right? It was like Velcro. And so what the uterus is going to do now is it's going to contract down on itself, basically putting pressure on itself to control that bleeding. So after the placenta is out, the midwife or the nurse or whoever's there is going to actually push on the person's belly and make sure that that uterus kind of contracts way down really hard. And sometimes they'll give it some massage to encourage it to clamp down even harder. And that's really important to decrease blood loss from the uterus at this phase. That's a potentially devastating complication if a woman bleeds excessively. So sometimes I get asked about placental encapsulation. You might be like, what is that? So I'm going to tell you. So here's a raw surface of the placenta. That's kind of what it looks like. So if you take the placenta and you slice it up into little bits and you put it in a food dehydrator, you can then grind it up in a food processor into a powder and then put it in little capsules, which then you can take. Now, why would anybody do this? Well, I think people got the idea because in many animals, in many mammals, the mother, after delivering the placenta, will eat it, right? So in the animal world, there are instances where animals will eat their own placenta, and you might think, well, what would the evolutionary benefit of that be? And if you realize the placenta is really, really rich in blood, there's a lot of blood in that placenta, and so that means there's a lot of iron there. And since women often lose some blood during the process of childbirth and in the week after, as the uterus is kind of going back to normal and healing over, right, making sure you get plenty of iron is a good idea. I would argue, however, that I would much rather eat a nice steak or some hamburgers, which are also really high in iron and a bit tastier. So we have other ways to make sure we have an iron-rich diet after childbirth, aside from eating our own placentas. The other reason why people sometimes advocate this is because there are also a lot of hormones in the placenta. So you'll recall in the 3rd trimester of pregnancy, the placenta is making estrogen, it's making progesterone, it's making relaxin, it's making lactogen, it's making all kinds of hormones. And so there have been some people who have theorized that the decrease in hormones that happens naturally after childbirth, because you've lost the pregnancy, right? The pregnancy has ended, and so estrogen and progesterone levels fall quite significantly after childbirth. Some people have posited that that decrease in hormones in the person's body increases your risk for postpartum depression, right? Or getting really depressed after childbirth. That's what postpartum means. And so they've said, well, hey, maybe if we take placental capsules, you are taking some of those hormones, and maybe that will help protect against postpartum depression, or maybe it will help with breastfeeding. There are all kinds of theories out there about why this might be potentially beneficial. However, there's no data to support that that actually works. And in fact, some of the few studies that have been done have actually, some of them have shown an increased risk of postpartum depression, and some have shown increased risk of problems with breastfeeding in people who are taking placental capsules. So at this point in time, there are no proven benefits, and there could potentially be harms. So although you may see it out there in magazines, there really isn't data to back it up at this point in time. So I would strongly advise against it because it could potentially be harmful, right? Like naturally, we weren't supposed to be having those hormones after childbirth. Okay. So at the end of everything, right, hopefully you end up with a happy, healthy infant and a happy, healthy parent. And so, yeah. So in 17C, we'll talk about some medical interventions, and in 17D, we'll talk about some complications of pregnancy and childbirth. So our summary for this stage of labor, right? So stage 2, fetal expulsion, mom begins pushing to move the baby down through the pelvis, out the vagina and vulva. And the fetal skull is specially designed so that it can kind of mold into a cone head shape to fit. Crowning is the stretching of the vulva that happens by the fetal head. And episiotomies, or cutting of that perineal skin, is generally not recommended. And we have to make sure that we get the shoulders out, right? Because sometimes they can get a little stuck. After the baby is born, it's a critical time of transition where it needs to learn how to breathe on its own as well as maintain its own body temperature. And we're going to cut the umbilical cord a few minutes after birth. And then the third stage is when the placenta comes out. So it's going to detach and can be pushed out. And then the uterus is going to clamp down on itself to minimize bleeding so that we don't have a hemorrhage situation occurring. And then I would say don't eat your placenta. All right, so that's it for 17B. I'll see you shortly with 17C.